Hello everyone, hope you're well and keeping safe. My name's Dr. Murali and this is Dr. Annie from Hippocratix, and we're joined today with a special guest, Talha Sami. Hi Talha, how are you doing?
Hello everyone, yes I'm very well, thank you.
Good. So Talha was one of our subscribers and was one of the first cohort in June of this year, so that's 2020, to have submitted RCA cases and successfully completed CCT. Congratulations. And he's kindly agreed to share his experiences with us today. So Talha, tell us a little bit more about yourself.
Thank you very much. So I was training as an ST3 in Guildford when this all happened. So we went into lockdown around March time, had my CSA booked, but then the picture changed, didn't it? And exams were cancelled left, right and centre. The college went into crisis mode and had to come up with something different because we had, I think, approximately 1,500 to 2,000 trainees who needed CCT. And the RCA is what we came up with. So fortunately, I was one of the ones to pass. And yes, thank you very much. So, but since August, I've been working as a GP.
And, sort of going with it, because you're one of the first cohorts of the RCA, you've clearly obviously had the right sort of experience regarding the RCA. Talha, are you able to sort of shed any light on the most common question we get from candidates and subscribers is, what cases did you submit? And how did you decide to choose those cases? Now, I understand you've got material available about all of this, which we'll put some links in the description for you.
I can see why that would be such a big question. That is ultimately the dearth of what we're trying to do and submit going forward. So, yes, I do have material on that on www.passtherca.com. I've run a course as well, and I've just published a book this week or last week now about what cases to submit. And I just want to share a lot more about that here. So I think generally as ST3 candidates, we will have a vague understanding, or a broad understanding, I should put, of what cases to submit. As GPs to be, we understand that what we deal with can vary from mental health to paediatric to obs and gynae, all in the space of 3 consultations. That opportunity presents itself to us naturally from the nature of our profession. So personally, what cases I submitted, I think is a good place to start. From what I can recall, I had at least 1 geriatric case, 2 MSK cases, a pyelonephritis, 2 obs and gynae cases, 1 mental health, a reflux, so a GI case, an ENT case. These are just some of the cases that I can remember off the top of my head. And I have a list on the handouts from the course about what cases not to submit, which the college has put a small amount out. And I go into some other details about what other things not to submit. But then a list of cases that you can submit. For instance, things like PSA counselling, HRT, these things are very common. They come about frequently. So these are things that we've got scope and room for to submit going forward. The last point I just want to make on this too is when we submitted, the college did not have fixed guidelines about what to submit. However, for the second cohort going forward, they have put together at least 6 criteria about what needs to be fulfilled. I would tell candidates not to fret too much because you will get them. Just by the nature of our job, all these things will fall into your lap, but you have to be very proactive as well. And I hope maybe we can talk about that too.
In terms of when we are giving advice to people who watch our videos or contact us via email, they ask about how they should go about recording cases. So we usually say to them, just make sure that you start early, record loads and loads of cases, and then use the cases that they have recorded to go through the mark scheme, analyse them themselves, and come to a short list of cases that they want to submit to their trainer so that they can have a look and try and get opinions from other people so that they can improve on their cases as much as they can and get the best ones to show the best of their capabilities. Is this the kind of thing that you did, recording lots of cases and then shortlisting them?
Yes, I think that's a great question as well. Again, it comes right to the crux of the issue. So if I reflect on my experience, and these are things I kind of feed back on the course after refining and talking and teaching program directors, trainees, and discussing with other ST3s as well, and getting the input from all of these as well. So I would say within the time from you decide to submit to submitting, let's say there's about a period of at least 2 months, maybe 3. In our case, I think it was about 5 weeks. In that time, I would suggest doing about 50 to 60 cases. That sounds like an awful big number, but if you break it down, that would be 1 good recording a day. I would advocate doing about 2 or 3 cases a day, and maybe one of those is a potentially good one to submit. You mentioned the trainer. Your trainer is your best friend within this time. So they're going to be listening to your recordings in the evenings, on the weekends. I actually discuss this within the book too. I say you need to make sure that you have a regularly scheduled time with them. So the tutorial is an excellent time for that within the week, but then they go on leave, you go on leave, other GPs are not there. So you have to constantly get regular feedback from your trainer going forward. Ultimately, they are the best judge of how you will do, whether or not they've done the CSA or not.
And I guess there's every opportunity. Let's say you've got a 10 patient per session clinic and you're doing two in a full day, so that's 20 patients. That's almost 20 patients a day. You've got opportunity to be able to practice for the RCA, whether you're at your AKT level, or fair enough, if you're at AKT you'll probably be more worried about that, but from day one, when you start in general practice as an ST, it's every single opportunity you should take advantage of preparing for the RCA, because going in the future now, this is potentially post COVID, this is going to stick. This is going to be the future of general practice. Patient behaviours have changed. Patients are now adopting the telephone triaging approach, the video consultation approach, and that you're face-to-face, you've actually now realised, both patients and yourself, is actually a lot lower than it needs to be.
I think as well, ST3s now, and like with you sat the first cohort, there wasn't as much time for you to prepare. And you can always start as early as you can, getting your case library sorted and to get that together. And as you say, at least 2 or 3 months so that you can get all those good cases. I think the other thing that we also tell our trainees as well, that in terms of making sure you're getting the right cases, the RCGP had highlighted there was a lot of low challenge cases in the first cohort that were being submitted, which didn't show off trainees' skills. So the RCGP, as you've mentioned, they've got a whole list of suggestions on what you should be submitting, and a bit more specific now of what you should be submitting. But they do suggest, and we also suggest, to make sure you're submitting new cases and make sure that everybody is on board in your practice, your trainers, the receptionists who are booking in cases, to make sure that they know that you are getting new cases, not follow-up cases, so that you don't miss any opportunities to get a really good video.
Yes, I 100% second that. The reason being is this is a very multidisciplinary effort. I actually discuss this on the blog that we do, video and written, on passtherrca.com. Now, the reason being is because in order to get the cases, you have to have receptionists on board triaging them to you. You need to have your trainer to make sure that they're okay with it, they think it's suitable. Furthermore, you mentioned about having follow-up cases. So most of my cases were not follow-up cases, they were new. After all, that's what the college has suggested. That being said, I thought I would at least try, see what happens if I do a follow-up case. And this happened a few times. Those cases turn out to be a bit sterile, they turn out to be a bit flat, and they're not really submission criteria for going forward. As you said, every sentence is being judged. Every sentence needs to be accurate, appropriate, and worthy of getting marks. So if you're not doing that, then something's gone wrong, and that's when you may get those low challenge cases.
Yeah. And I think the other thing as well that we say is, because you haven't got the examiner there with the information that you've got in front of you, that it's really good for candidates to sort of verbalise what they're seeing. So if they've got a past medical history of diabetes, hypertension, that they verbalise that, and the drug history they verbalise, so that the examiner is aware of the background that you're seeing, and not to take too long doing it, but just make sure that it is in there. And
in the interests of teamwork, pre-COVID with a CSA type mantra, you're always an advocate of study groups, or using using people close to you to be able to critique your cases and critique the way you consult. Luckily, I had an ANU. My sister was great in trying to help me get through the CSA and help critique my cases. But okay, not everyone has an ANU, but at the same time, you've got all your colleagues who you do meet up on a regular basis in your VTS schemes, whether it be in socially distanced type of tutorials, or whether it be virtually. And you can always use that as an opportunity to be able to critique each other's cases and pick up tips and tricks from each other, which you would never even see if you just looked at the cases yourself. on top of that, you've got your educational supervisor. I told my last trainee to send as many as you can. It doesn't matter you shouldn't worry about how many you send in, because at the end of the day, your educational supervisor, along with everyone in your team in the practice, should be helping you to succeed and helping you to pass the RCA and, end up like Talha, where he's passed his CCT and done the RCA successfully.
I just want to pick up on a few things there that I think would be very helpful for people listening. I know you mentioned about structure. Now, I think we've maybe briefly discussed that you're doing the RCA, the remote consultation exam, which is real life patients, but you're doing it on a CSA mark scheme. These patients are not CSA calibrated. They're just real life, and they just want to get across what they want to get across. And that's fine. But you need to make sure you tick all of these boxes, or you at least get that criteria going. Now, when submitting going forward, you have to make sure that you delve into the psychosocial history, that what you do matches the structured history that you need. So, for example, I would like to just present a question to maybe you two and the viewers listening. If we're doing a cardiovascular history, at times maybe we wouldn't ask about family history. I certainly would have missed that at times. But now if you're doing RCA, you have to make sure that you're getting that structured history. You're not missing those points. So you have to bring forth and verbalize, as you've said.
And I think in addition to that, it has to be a targeted history. So this is when we were doing our tutorials and our courses for the CSA, there was a lot of people that would have their structure and be very rigid with their structure and have maybe set questions that they would ask, which were not always relevant. So it's making sure that you have a targeted history as well. And when you've got a targeted history, you'll get all the important points within that golden 10 minutes that you've got to record your consultation.
I mean, it's like it sort of brings about an almost positive aspect of the RCA, doesn't it? Me being the petrol head that I am would, suggest that the CSA was akin to a driving test on a racetrack, in that you've got a mark scheme, but you've got your road is controlled, the road being the patient. Whereas the RCA, yes, you're still doing it virtually, but at the same time, you're actually dealing with real patients, and it's more of a true reflection of, a driving test, isn't it? You're doing your structure, you're showing the examiner what you're doing, but with real life scenarios, and not controlled real life scenarios, actual real life scenarios. And that's a big distinction with the RCA, but it's also something you're not quite in control of as much as you would be in a CSA exam, which is the patient.
Exactly, and this is actually something I talk about on the blog, on the website, and I actually discussed quite at length in the book that I've written and was published last week, which is the only book, may I add, on the RCA. It's at $1.99 on Amazon. Now, coming forward to this point specifically, you've mentioned the CSA is calibrated, and I want to give you an example for this. If you say in the CSA, do you have a problem with sleep? Do you have chest pain? How's your mood? Those avenues would be shut right down. If they're not the crux of that case, However, within COVID, everyone's struggling with mental health. Everyone is struggling with sleep. Often as well, just within the Western world, modernity, we're not great at sleeping and self-care. All of our mental health suffer at time. So we could go on to talk about that for a couple of minutes, and that's fine to do in real life. But when you're recording, you have 10 minutes. If you go in a chest pain case to start talking about their sleep and sleep hygiene, maybe you're missing the point. That's maybe the best thing for them to hear that. Maybe you could do that in 12 or 15 minutes. But if you're trying to narrow down to submit a 10-minute case, how effective will that be as a recorded consultation? So these are just some of the dilemmas that occur with the RCA that I think we've probably not thought about till we get there. And that's why I wanted to put forward some educational material in the form of the tutorial, the book, and the site.
And that's it. You're not going to get a straight answer from a patient. We've all been through it, being honest. You would ask, you're talking about chest pain, you ask them about how they're sleeping. It's almost a little bit of instant regret, because now you have to cover the reason why, the psychological aspects of why they're not sleeping. And like I said, everyone has it. Everyone's not sleeping properly because of COVID. So that's a good point.
I think the other thing in terms of curriculums, you need to try and cover curriculum headings as much as you can, just to show off as many skills as you can in the different headings and show that you are competent. But there are obviously some cases which on the RCGP website, there are some cases that you shouldn't be submitting, which are not appropriate. But I think we were talking about before some cases, specific areas which wouldn't be appropriate for you to submit.
Yes, I mean, I think I can understand why people would be most concerned about that, because getting that batch of recordings that you need is tough. I was recording right till the last day of submission criteria, until the day you could submit, the deadline. And, I actually did end up using some of those recordings. Going back, I had quite a large batch, so I was relatively comfortable with my 13 consultations. However, I saw my candidates who maybe had 30 or 40, so it's still a very good number, I have to say, within the time that we're dealing with. But when it came to the final 2 or 3, potentially that's also what could make or break an exam. They felt a little bit less confident with those cases. I mean, I went in on 2 extra days. I just want to add some practical tips as well, and I mentioned these on the course too. When you upload the cases to 14 Fish, which is the current platform to do that, you have to put a little blurb, their age, their date, their demographics. Now, I was creating a logbook, which I entirely recommend, but I was doing that from home at times, anonymized. But when you need to upload, you can't obviously do that from home because you may not have the cases, or you need the patient details in order to upload it. So that then facilitated another visit to the practice to get it done. I mean, again, we're in emergency times, we're in a worldwide pandemic, so we have to change and adapt to it. But just these are little tricks that you're not going to know unless you've gone through it.
And also making sure you give yourself enough time to set things up, that the visually everything's okay, volume's okay, making time to allow, if you've got to record something again, that you've got that time to do it.
100%. I advocate within sort of the teaching that I do that, listen, I will give 1 week. That's a dry run. It's going to be laden with errors. You need to get your AV set up right. You need to get your own set up right as to how you can approach each case. And I actually I would like to think, a foolproof way of how to do that that I suggest in the book. Because that week you're going to record maybe, let's say, 5 to 10 cases. I threw all of those 5 to 10 cases away from the first week, and I couldn't submit them because 5 to 10 of them didn't, the audio wasn't there, or I wasn't happy with the way that I spoke, or maybe I missaid something, or I missed the entire point of the case. So you have to give yourself some breathing time to turn this around.
And practice makes perfect. So the more that you record, the better you're going to feel, the more relaxed that you're going to feel as well in front of cameras.
Yeah.
And the more cases that you practice doing, the easier it will be to come to you when you're actually recording.
And that's it. Your first case is going to be a bit pants, but your second and third case is going to be on, more on top of things, isn't it? Because you've had the practice to record and you've got the nerves out of the way of recording. And the second and third case, you're just focusing about the case in hand and how you deal with the patient. I mean, a lot of people always ask, have I done enough video cases? Have I done enough telephone cases? I mean, how did that work out for you?
Absolutely. I think that's a really important question and something we had on our mind as a first cohort. Now, to go back, the college did not say you have to submit these kind of cases. They have done that for the second cohort, where they said, here's a list of criteria, you must fulfill that. And I personally am wondering if going forward for the third, fourth, fifth cohorts, if they may end up saying, well, you have to do a telephone, you have to do a video. Now, in terms of myself, I just did telephone triage, and I think that's what most people did. And I try and teach people about the best way to do that, how to have your setup right, how to have your screen, the things you need at hand, and how you can approach each single case when you're recording and beforehand. But in terms of specifics, my personal advice is I would try video, see how it goes. But you're adding another level of complexity. Signal can go. They may not see you, hear you. I had the elderly, the elderly population, they've got their phone here, they can't see you, and, you're seeing their kitchen, that kind of thing. So it just adds another level of complexity. And when you kind of add another complicating factor in, it takes away from your rapport, maybe your thinking and your thought stream and the overall trajectory of the consultation too. So does that make a good 10-minute submission?
Yeah. I mean, video consultation does have its place in general practice for sure. There are situations in in general practice where, you know, a video consultation has been the difference between sending someone into A&E or doing a home visit to literally saying, don't worry about it, you're fine. Because it's almost like your digital end of bed test doing a video consultation. But you know, looking at my working week when I'm in clinic, I've probably done a handful of video consultations, and having, you know, if you're a candidate doing the RCA and worrying about the fact that you've done no video consultations isn't a reflection that you've done something wrong. It's just a reflection that actually you found that you don't need to use it as a tool in your case. It is just something that you're able to do over the telephone. So I wouldn't, you know, if you are worried about doing a mixture of telephone and video consultation, it's like Talha was saying, use what's appropriate and keep it as simple as possible.
Talha, with things like prescriptions, so with the cases that you recorded, if you had a patient that you were going to do a prescription for, would you do it there and then, or would you say, oh, I will send that over? Because there can be sometimes problems sending over medication if they've not got, especially if you're sending it over electronically, if they've not got a pharmacy, it will just eat up into your time of that 10 minutes.
100%. So one of the things in real life consultation, I mentioned this within the book too. Listen, in most consultations, you're probably going to have maybe a 12-minute, 13-minute consultation where you go get them from the waiting room, you bring them in, you do the consultation, may have an exam in there or not, you do the prescription, you give them the FP10 if it's not electronically sent, and then you'll walk them back out. There's a lot of extra factors in there that complicate the picture, so maybe not so suitable for 10 minutes, and this is where the novelty of the RCA comes in and how we adapt for it. So you do get a lot of questions after the 10 minutes. So everything you need to say within 10 minutes needs to be spot on. I would say my advice would be saying something quite simple, straightforward is, I'll send it wherever you normally send it. I'll make sure you get the prescription. We can discuss that after the 10 minutes. So maybe this comes into another point to bring in, is when you record, you can either record offline, so not through 14 Fish, or through 14 Fish. Now, obviously, either which way, this is a bit new for the patients, and they may not understand how to go about talking and how to act within this. So in either which case, I prepared a spiel for whichever way I was doing, so then they would understand. Then they know this is a 10-minute case, and if something is maybe deemed to take up a lot of time, they'll understand, they'll get their time, but after the 10 minutes.
Yeah. I think that's a really good point and really good thing.
Just out of interest, because you're obviously using, you mentioned, Talha, about the 14 Fish platform that's the current one that they're using for the RCA, and that you can put things in the description. I mean, just out of interest, what is stopping you from putting in the medications you prescribed in the description? Is that allowed? Is that not allowed?
I think that's completely fine. I think an example I would give, I don't think this is something that I submitted, but for example, you could say something like, a 45-year-old man presented with abdominal pain with no red flags that was treated with omeprazole.
Yeah.
I think that's a really good case summary, gives everything in there that you know. And then when you do your logbook, which the college have suggested, you need to have, you know, an ongoing, updated in real time every day logbook of which cases you've submitted and what you don't need. So again, this comes back to having the practice on board.
Yeah. Okay. So I think we'll have a look at wrapping things up. But just before we do, Talha, I understand that you watched some of our videos and you were watching them sort of before the RCA came as well during your training. Did you find them helpful for you?
Absolutely. I found a lot of your videos helpful, actually, for the whole registrar experience. It's quite targeted, which makes it very, very useful, specifically for exam preparation and specifically for the RCA. I know you did RCA cases. I think as aspiring GPs and people going through that exam experience, seeing something practical is very, very useful, because then it gives you an idea of what you need to do. And specifically with how the videos were done, obviously very relevant cases and well presented, but the technical side where you had the mark scheme up as well at the same time, it kind of just gave you the 360 of what you need going forward. So I found that very helpful in contrast to some of the other RCA cases that are on YouTube. They're not like that. They might just be the audio recording and that's it, and a picture of something. So I did find them very beneficial.
Brilliant, thank you. Now, you've been really, really busy since you completed your training, and you've mentioned your book and your blog as well, and we're going to put some links down below so that our viewers can also have a look at that. Can you tell us a little bit about what you've been up to?
Oh, absolutely. So since I finished, one of the things I wanted to do was really try and give people a greater understanding about the RCA, because it's so novel and I learned so much. So what I did was I put together a tutorial that's available at passtherca.com, and people can just email me through that. Right now it's £25, which I think is a very reasonable price for getting all these tips. And then I appreciate that's not for everyone, so I put a book together, which is the only book, may I add, on the RCA, and that's $19.99, available on Amazon. Furthermore, the tutorial, I just want to add to that, what I think specifically makes it stand out is that it's a trainee's experience. Yeah. The trainee's experience is going to be very different from the trainer. Most trainers have not done the CSA. I've done this RCA, so I understand firsthand the difficulties from cases, the medicine, submission criteria, and it comes with many handouts as well to top it up. I do put together a number of free resources as well. My YouTube channel is So Far Unsaid. We're doing a blog on the RCA and a vlog on the RCA, and there is a written blog as well on the Pass the RCA website too.
So thanks very much, Talha, for talking to us today. Don't forget to check out his blog and his book on Amazon, which we'll put the links down in the description for. Don't forget to subscribe to our RCA videos on www.hippocratix.com. We have added to our library 20 more videos and more to come in the future. Also, check out HX Community on hippocratix.com for subscribers. There are a few parts of the forum that are available for people who are non-paying subscribers. Feel free to drop us a line. We do check it fairly regularly. We are going to start posting more things on there, so stay tuned. And on that note, I will say bye-bye from all of us here. And take care and stay safe.
Bye-bye.
Bye-bye. And I hope you all pass the CSA and do quite well.
Really pass the RCA.
Ah, damn it. I was doing so well. So where should I take that bit from?
You can leave it in as like a little blooper at the end.
Yeah, that's good. Yeah.